Hi, this is Andrea Kane, and I'm here with you for HIT 120 Pharmacology, and we are now on week 4. We'll be looking at chapters 6 through 10 in your textbook on pharmacology this week, and covering unit objectives 9.1.6, 9.3.1, 9.3.2, 9.4.1, and 9.4.2. If you want to open up your book, you're welcome to do that. The slides do basically follow the chapters. Okay, so this week we're really focusing on the autonomic nervous system and those drugs that impact that. If you look at our PowerPoint, we're going to be covering a quick review of the autonomic nervous system. We'll be talking about what are the transmitters and receptors that are utilized by the ANS. We'll very briefly touch on the general rules of innervation, and I will tell you right now that won't be on your quiz. Then we're going to go into the actual drug categories of the cholinergic agonist, the cholinergic antagonist, the adrenergic agonist, and adrenergic antagonist. Now I want to stop there for a minute. When you see colon, C-H-O-L-I-N, when you see that, I want you to think acetylcholine, because anytime you're talking about cholinergic, you're talking about drugs that mimic acetylcholine. So keep that in mind. When you're talking about adrenergic, think of the word adrenaline. And that comes from norepinephrine and epinephrine. So anytime we're going to be talking about the adrenergic drugs, or even norepinephrine or epinephrine, you want to be thinking that these are adrenaline. They're focused on norepi and epi. And then we'll talk a little bit about pathophysiology, homeostasis in the nervous system, and I want to emphasize again, it will not be on your quiz this week. It's there because it's got some really good information that I think is helpful for you to know, but again, it will not be on your quiz. And then we'll review questions for the quiz. It doesn't look like much, but unfortunately, once I got going, there were a lot of slides, so we'll keep moving forward. Okay, so the autonomic nervous system, why are we learning that right now? Why is that in front? It's because its pharmacology forms a basis for then cardiovascular and central nervous system pharmacy. So if we talk about autonomic nervous system pharmacology, then next week when we go into cardiovascular, it'll make it easier. And we will touch on central nervous system pharmacology this week. But we'll also be talking about it as we move forward with some of the other drugs, particularly when we get into talking about ones that involve muscles. All right, so the nervous system, if you think back to anatomy and physiology class or even medical terminology class, the nervous system is made up of two main parts, the central nervous system and the autonomic nervous system. Okay, so in your mind, the equation should be central nervous system plus autonomic nervous system equals the body's nervous system. The central nervous system, or the CNS, is made up of the brain and the spinal cord. The autonomic nervous system, the ANS, is made up of somatic nerves that influence, shall we say, the muscles, and autonomic nerves that influence the heart, the GI tract, glands, and it is this autonomic nervous system that is responsible for maintaining the internal environment of the body, which is known as homeostasis. So make sure that you know central nervous system plus autonomic nervous system equals nervous system. Make sure you know that the brain and the spinal cord are the CNS, somatic nerves that control muscles, and autonomic nerves that control the heart, GI glands, the heart and GI tract and glands, is the ANS, and that it's the ANS, and more specifically the autonomic nerves, that control the internal environment of the body, which is known as homeostasis. Autonomic nerves are either considered sympathetic or parasympathetic. And again, this is something you need to know. If they are sympathetic, they are known as energy burners. If they are parasympathetic, they are known to conserve energy. Sympathetic reaction is fight or flight. This is what gives, if you're in a high fear, high energy situation, this is your body's urge to all of its cells to fight or flight. These are the sympathetic ganglia are located close to the vertebral column in the thoracic and lumbar regions of the spinal cord. So think about that. In your back, your vertebral column, the thoracic, which is chest, the lumbar, which is lower back, that's where these ganglia are located. Their postganglionic fibers can be very long and are spread out kind of like a web. And these are the ones that encourage your body to have a fight or flight reaction, where you feel flooded, and all of a sudden your heart's beating fast, and you're gathering your energy to go and do something significant. Parasympathetic, on the other hand, is the group that says, hey, calm down, it's okay, relax. And that's the influence it has on the body. It is causing that release of energy, that, okay, we're going to hang on to our energy, it's all right, just relax. The parasympathetic ganglia are located in the brainstem and near the sacral region of the spinal cord. So if you think about the sacrum, it's the very last part of the spinal cord area in the vertebrae. And then in the brainstem, that's going to be really close to the neck. These ganglia are located close to their target organs. They're not fixed along that vertebral column. So their postganglionic fibers are shorter, and they have a more localized action because they're not spread out like a web like the sympathetic ones are. So keep all of this information in mind. Within the ANS, there are two neurons that are required to reach a target organ. There's a preganglionic neuron and a postganglionic neuron. All preganglionic neurons release that acetylcholine as their transmitter. Okay, so let's stop right there. Whenever you've got a target organ, you've got two neurons that have to reach it. You've got the preganglionic, the postganglionic. And the pre are releasing acetylcholine to transmit to that postganglionic neuron. The acetylcholine binds to nicotinic receptors on that postganglionic neuron. So in your mind, be thinking preganglionic neuron, acetylcholine, nicotinic receptors on that postganglionic neuron to get to that organ, that target organ. All of the parasympathetic postganglionic fibers release acetylcholine. At the target organ, that acetylcholine interacts with muscarinic receptors, and these muscarinic receptors are predominantly found in the GI tract. Most of the sympathetic postganglionic fibers release norepinephrine. At the target, norepinephrine is what interacts, and they do it with a variety of receptors. So let's go back here. We were talking about a preganglionic neuron and a postganglionic neuron. And we were talking about how the pre releases the acetylcholine, and that binds to nicotinic receptors on that postganglionic neuron. But then you get to the parasympathetic postganglionic fibers. Those release acetylcholine, and they're interacting with muscarinic receptors. But at sympathetic postganglionic fibers, those are releasing norepinephrine, and they can interact with a variety of receptors. So try and, if you can, get that straight in your mind. If you can't, it's not the end of the world, but it will help you as we continue moving forward, talking about all these different classes of drugs and how they work. And the last is just an FYI that somatic nerves or muscles use acetylcholine as a transmitter and bind to nicotinic receptors. And the adrenal medulla also has nicotinic receptors. That's more just trivia than anything. I don't use it in the quiz, but it is good to know. So let's summarize what we've been learning. Acetylcholine is the most critical organic chemical transmitter for the normal function of the brain and the body. Because you think back, it is being used as a transmitter on all preganglionic neurons to postganglionic neurons, regardless of what they are, and then it's being used on all the parasympathetic postganglionic fibers to interact with muscarinic receptors. So that's why acetylcholine is so critical. It contracts smooth muscles, it dilates blood vessels, it increases bodily secretions and slows heart rate. It is essential for thinking and working memory. Make sure you know that. Make sure you know what acetylcholine does, because that will help you when you're starting to think about drugs. You'll think about whether they're cholinergic or adrenergic. This last piece kind of summarizes what we've been talking about. Not quite so critical. But just know that all autonomic nervous system ganglia have nicotinic receptors. All receptors at the neuromuscular juncture are nicotinic. All target organs of the parasympathetic nervous system are muscarinic. If I had to pick and choose what you need to know on this slide, it would be it contracts smooth muscles all the way through working memory. That's the most critical. So let's take a look at a visual on this, on how this actually works. Whoops, my mouse is moving. Okay, your central nervous system, that's your brain and spinal cord. Your peripheral nervous system or autonomic nervous system, this is all the nervous tissue that's outside of the CNS. The way it works is you have these receptors. They send this sensory information. Whoops. It goes through and is processed by the brain. And then the brain says, okay, here's what we're going to do. And it sends these commands out through the peripheral nervous system. And you have your autonomic piece of that, and you have your somatic piece of that. And as you come down through the autonomic, you have parasympathetic and sympathetic that are controlling smooth muscle, cardiac muscle, glands, adipose tissue. Whereas your somatic nerves are controlling skeletal muscle. So this is really what we're talking about here. From somatic, where it comes out of the brain and spinal cord, it's moving through, it decides, oh, I need to go through skeletal muscle, or no, I need to go through non-skeletal muscle, which is either parasympathetic or sympathetic, that controls smooth muscle, cardiac muscle, glands, adipose tissue. And what this does is it shows you, okay, here's your brain, and you have your brainstem, and then you have the spinal cord, and it shows you how the sacral area, what it's influencing in the parasympathetic system, and then you have the thoracic and lumbar and what it's influencing in the sympathetic nervous system. Okay, so you can see that if it's doing parasympathetic work, nervous work, it's going to constrict pupils, increase saliva production, reduce heart rate, constrict bronchia, stimulate the activity of your digestive organs, stimulate the activity of the pancreas, stimulate the gallbladder, constrict the urinary bladder, and stimulate the sexual organs. On the sympathetic side, then, it's dilating the pupils, which is opposite, right? It inhibits saliva production, dilates the bronchia, raises the heart rate, inhibits the activity of the digestive organs, inhibits the activity of the pancreas, inhibits the gallbladder, stimulates the adrenal medulla in the kidneys to release adrenaline and noradrenaline, which is known as epinephrine and norepinephrine, relaxes the urinary bladder, and stimulates the sexual organs. Okay, so we've got these. Notice how they are opposites. Okay, and be thinking, remember, sympathetic means fight or flight. Parasympathetic means it's okay, calm down, everything's all right, conserve your energy, whereas the sympathetic is, ooh, burn that energy, move, do this, do that, or get ready to go. We're going to be, expending all this energy. So make sure you know these differences, because then when you can think about it, okay, if if this drug is targeting the sympathetic receptors, then you know these are what it's trying to do. And it's easier to predict what a drug will do. All right, so this is a little bit clearer of a slide, and it shows us again the same thing that we were talking about, how you have a preganglionic neuron and how it releases acetylcholine. Then you have your postganglionic neuron. On the parasympathetic side, it's going to release acetylcholine at the target organ to rest and digest. On the sympathetic side of life, it's going to release, at the end of that postganglionic neuron, it's going to release norepinephrine. And that's going to hit the target organ, and you're going to get a fight or flight response. So do you see how this makes sense? How we're building on this, and why we need to know whether it's parasympathetic influencing or sympathetic influencing, and why it's a cholinergic or an adrenergic agonist or antagonist. And what we learned last week about agonists and antagonists is very critical, because that's going to tell us what it's going to do with acetylcholine or norepinephrine. So, kind of to summarize, the synthesis, storage, release, and removal of transmitters is important because there are drugs that target each of these steps. That's really the bottom line with pharmacology. Pharmacology is the study of drugs that are created or developed or synthesized to the point where they are functioning on the synthesis, storage, release, and removal of transmitters. And transmitters the main transmitters we're going to talk about are acetylcholine, norepinephrine or epinephrine, dopamine, which we'll get into, and then they're acting on those transmitters, and those transmitters have specific main receptors that they work with. And we talked a little bit about this. For acetylcholine, it's seeking out either muscarinic or nicotinic receptors. For norepinephrine, epinephrine, or dopamine, they're going to seek out alpha or beta receptors. You've got to know this. You've got to know that acetylcholine searches out muscarinic or nicotinic receptors. And norepinephrine, epinephrine, or dopamine, those three are all seeking an alpha or beta, or both, receptor. In order to target drug action to the correct organ, drugs have been identified or designed to affect only one or two receptor types. And that's how they can get the specific action that they're seeking. So let's take a look. And this is another picture of exactly what we've been talking about, a little bit busier and a little bit more detailed, but I think it might be helpful. So you're up here at the top with the sympathetic. And you can see you got your acetylcholine here between the preganglionic and the postganglionic. And notice that they're reminding us that there's nicotinic receptors, because this is sympathetic, remember. And then you get to the end, and it needs norepinephrine, which is an adrenergic, and it's looking for receptors there. Okay? And these receptors, remember, norepinephrine is looking for an alpha, beta, or both. See, that's the A's that's there. It's looking for alpha or beta. It's not looking for nicotinic or muscarinic. It's looking for alpha or beta. Okay, so this goes down into an exception. And then, and it's talking about sweat glands. So if we talk about sweat glands, it'll get that specific. Moving down to the adrenal medulla part of this is also a little bit different, but it's still using ACH. It's on this case, because remember we talked about how the adrenal medulla and the somatic muscles, they do use nicotinic receptors there. There is some epinephrine involved from the organ, from the target organ moving out, but it's not a part of this process. So the ones I want you to focus on are the very top one and the very bottom one. And the very bottom, remember, is the parasympathetic. It's using acetylcholine here as it moves to the postganglionic, and then which has those nicotinic receptors again, and it's using ACH, acetylcholine, and looking for muscarinic receptors. So compare the first one with the last one. What's different? What's the same? What's different? This slide right here, this piece on the left-hand side that has all of these visuals is just so important for us to be able to understand how the drugs are going to work. And if you're still not sure about neurotransmitters and receptors, this information here on the bottom right should be helpful to you. All right, one more. This is showing you whether it's the autonomic or the somatic nervous system. It's showing you what's happening at those different junctions and what's happening at the target organ. And this is just another visual to explain it in case you were struggling with the last one. I wanted to give you a couple of different ones because I know for me sometimes one might explain it, but I'm still not quite sure, but another one might for some reason click with me. And so that's why you've got both. So again, acetylcholine is going to be looking for a nicotinic or muscarinic receptor at the target organ. And then you have in the sympathetic system, you have where they're going to use norepinephrine or epinephrine at that target organ, and it's going to be looking for alpha or beta receptors. And then there are some drugs, and we'll talk about two of them specifically this week, that look for alpha and beta receptors, but most look for alpha or beta at the target organ. Okay? And acetylcholine, again, is critical in all of these because of how it acts in the middle between the preganglionic fiber and the postganglionic fiber. So make sure you know that. And whenever you see adrenal medulla, the adrenal glands sit on top of the kidneys. So if you're thinking back, that's where they're at. They're sitting on top of the kidneys, and they have an awful lot to do with how things are released, hormones and things like that. All right, general rules of innervation. I'm going to cover this very briefly, but it will not be on your quiz. So innervation is essentially where you've got parasympathetic and or sympathetic nervous systems influencing it. Sometimes these organs are getting innervated from both. So they're getting fight or flight on one side and relax, it's okay on the other. What do they do? Because that would seem to be very conflicting. The rule is that when the same organ is innervated by both, they will have opposite actions. So if the organ is in a resting state when it happens, the parasympathetic system will usually win out. If it's in an active state when this happens, then the sympathetic system will win out usually. Most vascular smooth tissue is innervated solely by the sympathetic nervous system. And that means, so for blood pressure and peripheral resistance, the sympathetic nervous system is going to win out every time if there's a competition between sympathetic and parasympathetic, which makes sense. Okay, let's dive into cholinergic agonists. So cholinergic, it's acetylcholine. These are drugs that increase activity by mimicking the action of acetylcholine. They have a direct action on a specific type of receptor for acetylcholine that's going to either be muscarinic or nicotinic. So one type of cholinergic agonist is bethanechol. This treats neurogenic urinary retention. Another type of cholinergic agonist is nicotine. And although nicotine at times seems to be addictive, it can be used to help reduce desire to smoke tobacco. Seems counterintuitive, but there it is. Side effects of bethanechol and nicotine include sweating, salivation, GI distress, and cramps. So let's go on and talk about bethanechol. With neurogenic urinary retention, have you ever heard of that? It's a condition where the bladder is lacking control due to brain, spinal cord, or nerve damage, or the nerve fibers are experiencing an inability to function. It can be the result of diseases such as multiple sclerosis, Parkinson's, or diabetes. It can also be caused by infection. It can happen post-surgery or post-delivery when the body is really stressed. Failure to treat neurogenic urinary retention can cause kidney damage. Most of these patients are definitely catheterized, but they also require medication. And that's where bethanechol comes in. It's a parasympathomimic, so it's miming or it's imitating, shall we say, acetylcholine on the parasympathetic system. It's going to stimulate muscarinic receptors without affecting nicotinic receptors. And there are a couple of visuals to show you how this happens. You don't need to know any of the detail on this, but this is an example to help you see how so often there's influence there. So essentially what's happening is, for some reason, there's not communication between the nerves and the brain. The brain is sending the message that the bladder needs to empty itself, but the bladder's not getting the message. So somewhere along the line, there's some kind of damage or inability to function. What the drug does is it comes along and it skips through and it provides whatever is missing to get that message. It provides the acetylcholine level that is needed to get the message across and to the organ. So that's what it's trying to do, so that the bladder will know to contract and relax and release the urine. Okay, so let me go back. Cholinergic agonists. Think about those agonists. They're going to increase the activity of acetylcholine. All right. Now let's talk about cholinesterase inhibitors. Acetylcholine is broken down by the enzyme acetylcholinesterase. Anytime you see esterase, you want to be thinking enzyme. An enzyme is something that breaks it down, destroys it. So think about a cholinesterase inhibitor is a drug that is going to stop acetylcholinesterase from breaking down acetylcholine. It's going to act as a blocker so that the concentration of acetylcholine can be increased so that the messages can get where they need to go. There are a couple of types of cholinesterase inhibitors. There's reversible or water-soluble versus irreversible or lipid-soluble. The reversible or water-soluble, a good example of that is donepezil. And that is known under the brand names of Aricept and Exelon that treat Alzheimer's to increase thinking and working memory. Pretty much any irreversible lipid-soluble cholinesterase inhibitor is going to cause death in many ways, especially if it's in a high concentration. Low concentration ones are used for glaucoma and to reverse anesthetic after surgery, specifically the anesthetic agent rocuronium. It helps patients wake up. in its purest form, shall we say, strongest, purest form, it is used as a fatal nerve agent in chemical warfare. So the side effects of these drugs are the same as a cholinergic agonist: sweating, salivation, GI distress, cramps. Because again, a cholinergic agonist and a cholinesterase inhibitor do the same thing. They increase the concentration of acetylcholine at those synapses to increase the messages getting to the organ and telling the organ what to do. An example is myasthenia gravis. This is an autoimmune, and so anytime you see the word autoimmune, think of your own body's creating antibodies that attack. So your body's attacking itself. It's a disease with a loss of acetylcholine receptors at the neuromuscular junction, resulting in weakness and fatigability of skeletal muscle. Androphonium is a short-acting cholinesterase inhibitor that's given by IV for patients that are suspected of having myasthenia gravis. Neostigmine, pyridostigmine, and ambienonium are longer-acting cholinesterase inhibitors for patients with confirmed myasthenia gravis. So let's take a look below. I give you an example of a neostigmine vial so you can see what that looks like. And obviously it says for intravenous use. The graphic on the bottom right shows you a normal neuromuscular junction where you've got acetylcholine and it's hitting the receptors and causing the muscle to contract appropriately. Then the next picture is neuromuscular junction in a patient who has myasthenia gravis, where you can see that those antibodies, the way they're attacking is by blocking the receptors. So they're blocking the receptors. The acetylcholine is still there, but much less of it can get through because there's fewer receptors for it to attach to. Those antibodies act as an antagonist, so to speak. And with that reduced transmission, there's impaired muscle contraction. And that's why they've developed a drug that goes in and it increases the concentration of ACH so that you can get closer to that normal muscle contraction, even if you've got those antibodies that are blocking receptors. Cholinergic antagonists. Now remember, agonists and cholinesterase inhibitors, they increase the concentration of acetylcholine at those synapses, at those junctions. An antagonist is a blocker. It's going to get in the way. It's going to keep them from getting close. It has no effect of its own. It's just going to keep it from getting there. Because remember, we have competitive ones and we have non-competitive ones. Competitive ones are, they give the acetylcholine a chance when they gently release. If you increase the level high enough, it can get past the antagonist. And so that's one of these, that's this situation here. That these cholinergic antagonists, they're blocking the release, they're blocking acetylcholine from attaching to its receptors. There are two examples, atropine and scopolamine, sorry about that, and they're competitive, so the only way you can get past them is to increase acetylcholine. What do? Atropine is used for surgery, pre-surgery. It's definitely a drug to relax, but almost, I don't want to say paralyze, but definitely it subdues someone. Interestingly enough, it's also been used successfully with mushroom poisoning. Scopolamine is used for motion sickness. It's, as you can see at the bottom, I've put there the packaging, and you can see that is a little patch, a transdermal patch that you put right behind your ear. and its goal is to prevent motion sickness, reduce postoperative nausea, vomiting, and that sort of thing. Side effects for cholinergic antagonists are opposite of cholinergic agonists. So you have less sweating and flushing, you have less GI motility and lower secretions, you have bronchial dilation instead of bronchial constriction, you have an increased heart rate at high doses, you have urinary retention. Because remember, cholinergic agonists were used to relieve urinary retention. Cholinergic antagonists cause urinary retention. Can also result in drowsiness, hallucinations, and coma. Some additional examples of cholinergic antagonists include succinylcholine and botulinum toxin, also known as Botox. Let me go back here. One thing that I was pointing out here is that these are taking place at the nicotinic or muscarinic receptors. And it's the same for these as well. So succinylcholine is an anesthesia. It's used a lot of times with intubation or mechanical ventilation. You need to relax that patient, almost paralyze them to be able to do what you need to do, and that's what this drug does. Botox is used for prolonged muscle spasms, migraine headaches, excessive sweating, and wrinkles. They are competitive antagonists, and they are at the nicotinic receptors. And I think that's, yeah, the atropine and scopolamine are at the muscarinic receptors. Okay, not sure that that's helpful to know, but could be. So atropine and scopolamine, they target muscarinic receptors, blocking those. Succinylcholine and botulinum toxin or Botox, they are focusing on these nicotinic receptors. And again, their side effects are exactly the same as other cholinergic antagonists. That means they're the opposite of cholinergic agonists. Let's look at migraines. This is where they have found that Botox is very helpful for migraine headaches. They can inject it in small doses, sometimes up to 31 spots around the head and neck. And what it does is it stops that muscle spasming. And so this just gives you some information about that. Adrenergic agonists. Okay, now we just talked about the cholinergic agonists, the cholinesterase inhibitors, and the cholinergic antagonists. That was all acetylcholine. We are done with acetylcholine. We are now moving on to adrenergic category, and that is focusing on norepinephrine, epinephrine, or dopamine. So make sure in your mind, when you think cholinergic, you're thinking acetylcholine. And you're thinking muscarinic, nicotinic receptors. When you think adrenergic, you've got to be thinking this is going to be norepinephrine, epinephrine, or dopamine, and they're going to be looking for alpha, beta, or alpha and beta receptors. Okay, so make sure you know that. All right, adrenergic agonists, they're going to mimic the effects of norepinephrine or epinephrine. And epinephrine is also known as adrenaline, and that's where you get your adrenergic. So they mimic those, just like the cholinergic agonists mimic acetylcholine. So these drugs that are acting like norepinephrine or epinephrine, they can contract most vascular smooth muscle. They can increase heart rate, relax respiratory and uterine smooth muscle. And they have their focuses. If you notice here, epinephrine activates alpha 1, beta 1, and beta 2, whereas norepinephrine really focuses on alpha 1 and beta 1. You don't need to know that level of detail, but you do need to know that epinephrine is used to treat allergic reactions, bronchospasm or asthma, shock, cardiac arrest, localized bleeding, and prolonged local anesthesia effects. Sometimes they'll use adrenaline or epinephrine with a local anesthetic that they're treating because it'll help when they inject it and say they're putting in stitches, significant stitches. By adding that epinephrine, it causes that local anesthetic like lidocaine to last longer. So that's why they do that. Norepinephrine is used to treat heart failure, very low blood pressure, ADHD, which is attention deficit hyperactivity disorder. Sorry, my brain stopped there for a minute. Depression, PTSD, post-traumatic stress disorder, and sometimes substance abuse. So on this slide, you need to know that adrenergic agonists act like norepinephrine or epinephrine or dopamine, and we'll talk about dopamine in a bit. They can contract most vascular smooth muscle, increase heart rate, relax respiratory and uterine smooth muscle. Epinephrine is used to treat these things. Norepinephrine is used to treat these things. Please make sure you know those. And this is a vial here of norepinephrine, and at the top it's an EpiPen that's used to provide epinephrine in an allergic reaction situation. Okay, so we talked about that they mimic epinephrine or norepinephrine. What are some examples of these adrenergic agonists? A very, very common one is phenylephrine. That is a decongestant and vasoconstrictor. It's used in all sorts of Actifed products, Advil congestion relief, children's Dimetapp, children's Mucinex, Robitussin, Sudafed PE products, Theraflu, Tylenol cold or sinus products, Vicks Dayquil. If you go out and you look at phenylephrine and you look at what all it's in, it's an incredibly long list. But it's used primarily for cold, allergy, or hay fever symptoms, as well as sinus congestion and sinus pressure symptom relief. Interestingly enough, phenylephrine is also used in preparation H for hemorrhoids to reduce inflammation. Clonidine is a sedative and also an antihypertensive. It's used in brand name products like Catapress, Capvay, and Nexiclon for ADHD. Albuterol is a very, very common adrenergic agonist. It's used to treat or prevent bronchospasm, asthma, COPD. It's an inhaler. You see it in brand names like ProAir, Ventolin, Proventil, and other bronchodilator inhalers. And I've got a picture of an albuterol inhaler right there so you can see it. Another adrenergic agonist worthy of knowing is terbutaline. This is a bronchodilator, but it's also a tocolytic, and we'll talk about tocolytics in just a minute. It is used in inhalers for asthma and COPD. It can be used subcutaneously or IV for preventing uterine contractions during preterm labor. So make sure you're familiar with phenylephrine, clonidine, albuterol, terbutaline, and what it does. Okay, so tocolytic agents, what do? They cause the uterus to relax. There are 4 that are typically used together to delay preterm birth, especially if it's prior to 34 weeks. And you'll see on there the last one is terbutaline. It's an adrenergic agonist, and I've copied a picture of a terbutaline bottle so that you can see what that looks like. All right, dopamine. Dopamine is another adrenergic agent, but this one is made by the body as a neurotransmitter. Just like epinephrine, norepinephrine, it's made by the body. It has specific receptors. It plays a role in how we feel pleasure, think, and plan, and can influence our behaviors when it comes to reward or motivation. It impacts our memory and attention span, and it can also impact our body movements. A deficiency of dopamine has been implicated in Parkinson's disease and depression. And an excess has been implicated in mania, hallucinations, delusion, obesity, addiction, schizophrenia, ADHD, aggressiveness, binge eating, and gambling, interestingly enough. There is thought that dopamine levels can be naturally increased through eating habits, eating high protein types of things, exercise, getting plenty of good sleep, taking vitamins, being out in the sunshine, doing things like meditation or listening to music. At low doses, dopamine acts like norepinephrine. Okay, so please put that in your mind. At low doses, dopamine acts like norepinephrine. At intermediate doses, it activates the beta-2 receptors in the heart, and at high doses, it acts like epinephrine. And it is helpful in treating hemorrhagic shock. So at low doses, it can help with renal and coronary vasodilation. At high doses, it exacerbates heart failure, but it could be helpful with treating hemorrhagic shock. So what do you need to know about dopamine? Made by the body as a neurotransmitter, has specific receptors. It plays a role in lots of things. It is, at low doses, it acts like norepi. At high doses, it acts like epi. And then the next couple of slides are about dopamine and how it reinforces drug use. They have found through quite a bit of research that dopamine levels are heavily impacted by drug use, and it makes it so much harder for people who are addicted to drugs to become drug-free. Because as it points out here in the last paragraph, that it creates a reflex that can last a long time, even in people who haven't used drugs in many years, and they can experience cravings because the brain remembers. It involves that dopamine cycle. And so it shows you here how the drugs target the brain's pleasure center in terms of reward, and how it can increase and increase the dopamine. Increases, it exaggerates it, and that's where the pleasure comes in. So anyway, it's well worth reading about, well worth knowing about, but not on your quiz. Adrenergic agonists, another type. So we've talked about, when we're talking about adrenergic agonists, we've talked about phenylephrine, clonidine, albuterol, terbutaline, dopamine, and now we're going to talk about amphetamines. Amphetamines are a stimulant. Amphetamines are a stimulant. They are a synthetic, addictive, mood-altering drug that is often used illegally. It increases the rate of neurotransmission. It is used to treat ADHD, narcolepsy, appetite suppression for obesity, and Parkinson's disease. And there's some information here about that, as well as a couple of bottles of brand name amphetamines that are used usually to treat ADHD, and that's Adderall and Ritalin. Okay, on to adrenergic antagonists. So we've left the agonists behind. Remember, agonists, they mimic the norepi and epi, how those function. Antagonists are blocking that. Remember, they're not doing anything on their own because they can have no effect of their own. They're just simply blocking norepinephrine, epinephrine, dopamine from where they're trying to get the alpha or beta receptors. Now I'm going to talk first about alpha blockers, because there's alpha blockers and there's beta blockers, and then there's alpha and beta blockers. But I'm going to talk about alpha blockers first. These allow vasodilation that decreases blood pressure, used to treat hypertension, spasticity, and sedation. Side effects include postural hypotension and reflex tachycardia. An example is prazosin, and that's used to treat hypertension, urinary retention, benign prostatic hypertrophy, and PTSD. And there's a picture of a couple of bottles so you can see what those look like. These are alpha blockers. So you're thinking adrenergic antagonists that's blocking those alpha receptors from norepinephrine, epinephrine, or dopamine. That's what it's blocking. So by doing that blocking, it doesn't allow that influence of those on the organ. All right, let's move on. Oh, sorry. I have a slide here about how they impact the body. So adrenergic antagonists, when they are an alpha blocker, they will allow the eye to dilate, the lung to dilate, the heart rate to increase, blood vessels to constrict. They'll relax the GI tract, they'll relax the bladder, they'll relax the uterus. Side effects include orthostatic hypotension, vertigo, palpitations, and sexual dysfunction. And some examples they give you of alpha blockers include the clonidine and some others. All right, so let's talk beta blockers. Have you ever heard of beta blockers? These increase heart rate and contractility in the heart, respiratory tract, uterus, and blood vessels. Again, beta blockers. They're blocking epinephrine, norepinephrine, or dopamine from hitting the beta blockers. It's used to treat cardiac arrhythmias, angina, hypertension, hyperthyroidism, glaucoma, migraines, and anxiety. Side effects include bronchoconstriction, decreased heart rate, and cardiac output. Propranolol is an example of a drug that's used to treat hypertension, angina, atrial fibrillation, and tremor. So let's talk about beta blockers. What do? They slow that heart rate, lower the blood pressure. They affect those receptors in the heart and the blood vessel. They lower the heart's workload. Side effects include hypotension, CHF, congestive heart failure symptoms. So you have coughing, shortness of breath, extreme fatigue. You can have bradycardia, slow heart, or AV block. Can be very drowsy, can also experience depression. Propranolol is one that I gave you. They give you a couple of other ones. You may have heard of Lopressor. That's metoprolol, and that's a beta blocker as well. Okay, what happens when you have an adrenergic antagonist that attacks or that blocks both alpha and beta receptors? There are those. There are really only two, and they're labetalol and carvedilol. Have you been noticing the lol on the last couple of medications? It was OLOL, but you'll notice these are A and I. When it's A and I, they are mixed blockers, meaning they'll block alpha and beta. But when it's OLOL, it only blocks either alpha or beta. It blocks only beta because alpha is the Zin, Ozin. All right, so we're back here to labetalol. That's used for pregnancy-induced hypertension to bring that down, lower the blood pressure, and carvedilol is used with heart failure patients who have renal issues. They can't have just beta blockers alone. That may be too much for them, so they have to have something specific that doesn't put pressure on their kidneys. All right, so that is it for your textbook. Everything that we've gone through there is what is pretty much going to be on your quiz, and we'll review it one more time. But I want to move on to the pathophysiology because I think this information is helpful to know. Homeostasis is the mechanism by which the constancy of the internal environment is maintained and ensured. So it has to do with how things run. And because we're studying how drugs influence homeostasis or keep it this week, it seemed appropriate to go back and talk through what are some of the different things that influence that. So if you take a look, you'll see through here there's different types of pressure. There's different types of influence from the water in the body. There's influence when you talk about electrolytes, which is sodium and potassium. And it can indicate what's wrong when you start looking at someone's electrolytes and their water balance and whether they're dehydrated, overhydrated, underhydrated, or correctly hydrated. So hyponatremia, hypernatremia, hypokalemia, and hyperkalemia. These are 4 major conditions you will run across when you're coding. And this, I personally think this is a really great table because it tells you what causes those. So for instance, if someone's got more water than loss of sodium when they've got hyponatremia, it's either due to excessive use of diuretics, hypotonic irrigating fluid administration, excessive IV infusion of 5% dextrose, psychogenic polydipsia, large volume of beer consumption, or Addison's disease. Those are the major causes of that type of hyponatremia. And so you can kind of guess what they're gonna do. They're gonna back off. They're not gonna use any diuretics. They're going to try and bring back some of the sodium, and that sort of thing. So just looking through here, I think is well worth taking 10-15 minutes and understanding how that all works. I want to point one thing out. Under hyperkalemia, that's too high of potassium. Down here, use of drugs such as beta blockers can cause hyperkalemia. So you have to be really careful with that. Make sure that they don't end up with too much potassium. And that too much potassium has to do with how things are passing through. And then this talks here a little bit about acidosis and how when electrolytes are disturbed and the pH of blood is involved. This figure, I think, is very helpful. You hear a lot about heart failure, and we learned a little bit about drugs that treat heart failure this week. There are 2 types of heart failure. There's right-sided and left-sided. Left-sided, you want to be thinking lungs. Right side is everything except lungs. Left-sided means that there's pressure transmitted upstream of the heart, causing pulmonary congestion. Right-sided means that the pressure is transmitted down into the systemic venous area. So that can be liver, spleen, kidney, or legs. So I just think this is great information for you to know and keep in mind that if you're coding a chart, the patient's got heart failure, which side is it will help you know where the congestion is occurring or what to be looking for. And the same thing can tell you, okay, if they've got pulmonary edema, but they don't seem to have edema in their legs or feet, or they don't seem to have kidney problems, you know they're dealing with left-sided heart failure. Versus where if they're having kidney problems, they've got edema around their ankles, they've got pitting and that sort of thing, you know they've got systemic venous congestion, that's going to be right-sided heart failure. So it can just help you understand, because physicians don't always take the time to say left-sided heart failure, right-sided heart failure, but this way it helps you get that understanding. Okay, shock. I bring this out because we talked about that there was a drug, hint, 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 go back and look, that treated hemorrhagic shock. And I want you to know what that is. Hemorrhagic shock is a type of hypovolemic shock. And these, acute hemorrhagic shock. These are the different types of shock that you will see in charts. You'll see septic shock and all those other ones. This is helpful to know that these are the causes of the different types of shock. So that as you're going through, if the doctor says we've got cardiogenic shock, you're going to be looking for something that has to do somewhere with the heart. Whereas with septic shock, you're looking for infection. Traumatic shock, you're looking for severe injuries or trauma. Neurogenic shock, you're looking for something that involves the brain, spinal cord. So I think these are good to know, especially if you're going to be doing coding. And I liked this one because it talked about the 3 stages of the shock and what's going on a pathologic basis, but what you'll see documented in a chart that would lead you to understand where they're at in the shock, in the stages of shock. And then I think this is one of the last ones, and this is the nervous system. I like the fact that they showed you the different cells, nerve cells, but about the neurons, because that's what we're really talking about in this one. We're talking about neurons. We're not talking about all the other ones, and how they're shaped, how they work, how they connect, and how they communicate with each other. And then common degenerative diseases, thought this was helpful because we learned about drugs that treat Alzheimer's and Parkinson's this week. And you can see what their main features are, what the pathology is that kind of clues you in that this is what you're dealing with. And then this brought out about demyelinating diseases. We talked about multiple sclerosis at one point. That's a demyelinating nervous system disease, and you can imagine if someone has a demyelinating disease, how that impacts the transmission of those neurotransmitters getting through to the target organ to getting the outcome that you want. And we even looked at that with myasthenia gravis. So what you really want to know, what do you have to study for the test? Review questions. I need you to know, what are the two major parts of the nervous system? What are the two major parts of the central nervous system? What are the two major parts of the peripheral nervous system, also known as the autonomic nervous system? What are the two kinds of autonomic nerves? Think somatic and autonomic, remember? What do sympathetic nerves do? How do they influence the body to react? Where are their ganglia located? Are they long or short? What do parasympathetic nerves do? How do they influence the body to react? Where are their ganglia located, and are they long or short? What is acetylcholine? How does it work? What does it do? What are the two types of ANS receptors that acetylcholine interacts with? What are the two types of receptors that norepinephrine and epinephrine interact with? Hint, it's the same as dopamine. What are the two types of receptors that dopamine interacts with? How are drugs created to target specific steps in the process of transmitters or receptors? What are cholinergic agonists and what do they do? What are examples of cholinergic agonists? What are possible side effects of cholinergic agonists? What are cholinesterase inhibitors? What do they do? What are two examples of cholinesterase inhibitors? What are possible side effects of cholinesterase inhibitors? What are cholinergic antagonists? What do they do? What are two examples of them? What are some of the side effects that they have? What are adrenergic agonists? What do they do? What are two examples of adrenergic agonists? What are some of the side effects of adrenergic agonists? What is dopamine? What does it do? What does dopamine do at a low dose? Does it act like norepinephrine or epinephrine? What does dopamine do at a high dose? Does it act like norepinephrine or epinephrine? What are amphetamines and what do they do? What are adrenergic antagonists? What do they do? What's an alpha blocker? What does it do? What is one example of adrenergic antagonist alpha blocker? What are some of the side effects of these adrenergic agonists that are alpha blockers? What's a beta blocker? What does it do? What is one example of an adrenergic agonist beta blocker? What are some of the side effects of adrenergic agonist beta blockers? What is a mixed blocker and what does it do? What are the two examples we went over of adrenergic agonist mixed blockers? And what are some of the side effects of adrenergic agonist mixed blockers? That's what you need to know. These last 4 pages. If you can answer those questions, you will ace the quiz. All right, I hope you have a wonderful week. I look forward to talking to you again. We will come back and we will tackle chapters 11 through 15 in week 5. It's all about the cardiovascular system when we come back. Take care.